All right, welcome everyone. Thank you for being here. So this panel is called Does the Glove Fit? Finding the Right Ethical Framework to Justify Honoring Parental Requests in the Context of Pediatric End-of-Life Care. So we have three papers for you during this panel, and we have 90 minutes together. So our plan is to have the three presenters go one after the other, so each one will be about 20 minutes, and then we'll leave about 30 minutes at the end for discussion. So let me just introduce the speakers, and then we will go from there. So first, and I'll introduce them in the order that they'll be presenting. So I'll introduce all of them at once here. So Jenny Kingsley is an attending physician in the Division of Critical Care Medicine at Children's Hospital Los Angeles, CHLA. She's an assistant professor of pediatrics at the Keck School of Medicine at the University of Southern California and a faculty in the CHLA Center for Bioethics. Her primary academic interest is in shared decision-making in the ICU and at the end of life and ethics education. She's also an associate program director for the Critical Care Medicine Fellowship at CHLA. Dr. Kingsley received her undergraduate degree in sociology with honors from Rice University, her medical degree from the McGovern Medical School at the University of Texas at Houston, and her master's degree in bioethics and humanities from the University of Washington. And then after Dr. Kingsley, Pierce Randall will present. He is an assistant professor at the Alden March Bioethics Department at Albany Medical Center and a practicing clinical ethicist. Prior to coming to Albany Med, he was a fellow at the Stockdale Center at the U.S. Naval Academy. He completed his PhD in philosophy from the University of Pennsylvania in 2019. And then after him will be Xiang Yu. She is an assistant professor and clinical ethicist in the Institute for Bioethics and Health Humanities at University of Texas Medical Branch. Previously, she was a clinical ethics fellow at the Alden March Bioethics Institute at Albany Medical College, and she obtained a PhD in philosophy from the Ohio State University. Her research focuses on well-being, decision-making capacity, and psychiatric ethics. She and I will actually be presenting one paper. We're presenting it together. She'll go first, and then I'll present the second half. So my name is Daniel Kim. I'm an assistant professor and clinical ethicist at the Alden March Bioethics Institute at Albany Medical College. I was an ethics fellow at the MacLean Center from 2021 to 22. So I'm an alumni of the program here. And prior to that, I completed a PhD in religious ethics at the University of Chicago and an MPH from Yale University. All right, with that, I will turn things over to Jenny.
Hello. So as Daniel mentioned, my name is Jenny Kingsley. I'm at the Children's Hospital of Los Angeles, and I'm really honored to be here today. So this talk, my talk is based off of a paper that I published in the Journal of Medical Ethics entitled Navigating Parental Requests, Considering the Relational Potential Standard in End-of-Life Care. I have no disclosures, sadly. This topic was near and dear to my heart and still is, but really came to head when I was straddling responsibilities as a clinical bioethics fellow who was getting her master's at the University of Washington at the same time as I was doing my clinical pediatric critical care fellowship. And I noticed that there was a big gap in the way that parental requests for potentially invasive or harmful interventions at the end of life were discussed in my clinical roles as a clinician and a physician, and in my roles as an ethicist. And so I became really curious about the idea of how do we navigate requests for invasive treatments? And can we ethically justify considering a family's wishes explicitly when their child is close to death, even if those wishes confer risk or actual harm to a child? And it's a little bit of a leading question because I think that we can, and I started to think about what different ethical frameworks might help us answer this question. So I'm gonna take you along with me. We're going to be using a case that's a real case of a patient that I cared for in fellowship. And I'm going to talk about the case itself, the prevailing decisional framework that most pediatricians use called the best interest standard, propose an alternative or additional framework, the relational potential standard, and then talk about some of the objections. So our case. So Jane is a 3-year-old female. She has mitochondrial disease, and she is critically ill in the ICU with multi-organ failure. At baseline, she's severely developmentally delayed. She's dependent on technology for her activities of daily living. And she was initially admitted with acute on-chronic respiratory failure and has been admitted for a while, a couple of weeks. She progresses to have multi-organ failure with liver failure, and the medical team universally understands that she's dying and will not survive to discharge. Her family is consistently expressing desire for full resuscitation and to undertake any means possible to prolong her life. They express that they are very familiar with the medical system and see CPR as part of a standard of care package provided at the hospital. They cite that every moment that Jane's heart is beating is important to them, and they want to pursue interventions at all cost. Her team discusses potential intubation as her respiratory failure gets worse, and honors the family wishes to go through with intubation, and Jane has a cardiac arrest on intubation. She receives full resuscitation and with CPR, and additionally, eventually, return of circulation is obtained. But Jane has persistent hypotension. On the verge of what clinicians believe to be a second cardiac arrest, her parents request withdrawal of life-sustaining therapies. Jane dies in her mother's arms. For many people in the room who practice pediatric critical care medicine or who are ethicists who are involved in these cases, this is not an N of 1 situation. We have these circumstances quite frequently. And for me, it begs the question that since Jane died, regardless of the interventions performed, and since clinicians believed that she would not survive to discharge, were they wrong in intubating her and performing CPR? Some might argue that that was bad medicine, that we portended physical pain and harm to Jane, that we disregarded her best interest, we failed to change the ultimate outcome, and that, in fact, we gave potentially inappropriate treatment to Jane. That we abandoned our professional obligation to be good stewards of our knowledge and our skills, and performed procedures that were not indicated because they had a minimal chance of extending Jane's life. And maybe that time for clinicians was not felt to be meaningful. Others would argue no. Others would argue that we aligned with family values, that this is a representation of shared decision-making, that we aligned and protected the quantity of life for Jane and her family. We preserved parental decision-making authority, and some may hope, and this is an empiric claim, that we may provide the family with comfort. And so when I think about where I land with this, I think that when a child is dying, clinicians have a duty to serve both the patient and the family members, and that in some circumstances, the duty to serve family members becomes as important as that owed to a child. I think this is a pretty controversial statement. I will recognize that now. If we think of the triad of patient, family, and physician, I'm sort of hypothesizing that we could turn that over, and that patient, family, and physician might not look like the traditional triad that we think. So how do I argue that? Starting with the best interest standard, which is the prevailing decisional framework that clinicians use in a common sense word and that ethicists argue for commonly, I think we have to take a step back to understand why I think that this fails. So many of us in the room know that the best interest standard has several different formulations, and as argued, different authors argue that it can be used as a guiding principle, as a threshold principle, as a reasonableness standard, as a good enough standard. I mean, honestly, the list could go on and on and on. In cases like this, the best interest standard can fail because there's difficulty defining best. We fail to honor value pluralism that exists in this country, whether we as clinicians and ethicists want there to be pluralism or not. It can have an outsized focus on conflict when a clinician at the bedside believes that something is in the best interest of the patient and the family believes that there's something else in the best interest of the patient. It sets us up for failure by presuming that there's one single best option. And I would argue that by focusing solely on the interests of the pediatric patient, we are set up to ignore the social constructs and context that are so vital to the flourishing of any child. I love this quote from Erica Salter that says, "Because there are so many reasonable interpretations of what constitutes the best interest of a child, it functions merely as an empty, although sometimes alluring catchphrase." One of my mentors, Doug Diekema, will say, "It's probably not in my future child's best interest for me to buy Starbucks every day rather than putting that money to their college education, but no one's stopping me from doing that." I would argue that the best interest standard can fail us, particularly in pediatric death. The overwhelming majority of pediatric care is aimed at restoring health and helping children recover. But when that's no longer possible, when a child's future is short, there are very few interests on which to ground decision-making. We know that bereaved parents experience poor emotional and physical outcomes related to their grief. And we know that the care provided at end of life matters. There's empiric evidence to suggest that when mothers feel that providers have done everything possible, they have less complicated grief. When fathers feel that they have been given the opportunity to say goodbye to their child in the way that they would like, they have less complicated grief. And so I argue that we have a professional and moral obligation to try to do this better. When we think about our case and we think about the best interest standard, I think it becomes really apparent how this fails us. Clinicians are maybe focusing on the quality of Jane's life or what they determine to be the quality of Jane's life. Physicians we know focus on avoiding suffering, and we can recognize through work from Tyler Tate and Erica Salter that suffering in and of itself is a very subjective and value-loaded term. And we know that clinicians feel the need to fulfill the obligation to their patient. The family, on the other hand, has explicitly said that quantity of life is important to them, that they have an obligation to be good parents, and that that's what's guiding their decision-making about what they believe constitutes best interests. And so in circumstances where families pursue interventions that clinicians do not perceive to be in a patient's best interest, the BIS fails, or the best interest standard, sorry, I've shorthanded it for myself, to allow for nuanced and subjective and a variable approach that we need to navigate conflicts. And I think it's important to take a moment to acknowledge this caveat that the vast majority of cases, clinicians and families are going to agree, right? I think those of us in the room might be primed to believe conflict is not the exception because we are consulted when there's conflict. But I think that in my work as a clinician, the vast majority of times a family is going to agree with the recommendation by the provider and there's not going to be this conflict. But when there is, I argue that the best interest standard fails to really move the needle, and so I propose using the relational potential standard. The relational potential standard was initially proposed by RS for children with profound cognitive impairments. And it proposed that a child's capacity for self-consciousness and ability to form and maintain a relationship should guide decision-making. In this way, at the end of life, when a child maybe is sedated and is not able to have self-consciousness or maintain a relationship, in this traditional definition proposed by Eris, we would not be obligated to provide the care that the parents are requesting. However, based off of the work on Aaron Whiteman, we can turn this potential around and say that it's not really about the capacity of the child to do these things, but it's more about the capacity of the relationship itself to help a child flourish. So if we recognize the inherent moral value of that relationship, then we can provide care because we are enacting to preserve the moral importance of that relationship. I think it has a lot of benefits in that it respects family structure, preserves parental ownership of decision-making, and allows for a prioritization of family values and value plurality. In this way, it honors parental duty to be good parents, and it could reinforce the clinician-patient-parent relationship in a way that I think the best interest standard falsely dichotomizes things. I think it's important to note that I am not suggesting that clinicians abdicate their responsibility to make a recommendation to a patient and family. Using the RPS allows clinicians to acknowledge that decisions might be motivated by more than just the primary interest solely of the patient, but might be enacted or justified because of the relationship that that patient is in. So you can imagine there's a lot of objections. And I'm going to outline a couple of them. So I think the potential for harm is something that we need to, I think, probably comes to the forefront of people's minds. Clinicians may feel, and rightfully so, that they are the bearers of harm to these children and that they're violating their professional integrity. Clinicians will say that prolonging life to no meaningful end results in suffering or dignitary harms. And there's a concern for creating a slippery slope. How much will we tolerate? You'll note that I put meaningful in quotations and probably could put suffering or dignitary harms in quotations as well, because I don't think there's standard definitions or standard accepted definitions of what those actually mean. And I think what we often hear at the bedside, and I invite you to tell me what you think about this, is not that the child is suffering, but that we are. And that I would argue that we have a professional obligation, as harsh as this might sound, is maybe to bite the bullet, because we have experience with pediatric death when parents do not. I would also argue that the harm principle outlined by Doug Diekema might help limit the harm and might help us set some boundaries, and that we have to be able to ensure that the harm is transient and tolerable, that, for example, the drugs that we have in our back pocket and our toolbox for helping keep children comfortable, we use liberally and to good effect. I hear clinicians frequently say that they're concerned that parents are using children as a means to their ends, and that parents choose to continue life-sustaining therapies as a way to avoid their grief or as a selfish decision so that they don't have to say goodbye to their child. I would argue that that is a loaded statement and also isn't really supported by empirical work. Parents make decisions, they rarely make decisions for their seriously ill children out of selfish means. Now, I think it would be a pretty impressive study, actually, to get a parent to admit that. And I don't think parents actually feel that in their heart or their soul either. And I think we have to take that at face value. But I also think that we don't dismiss, if we use the RPS, we don't dismiss our obligation to respect the child as a person, and we need to take care to make sure that we are both telling families what we see if we're concerned about pain and harm, and also continue to advocate for them, but also recognize and respect that families might not agree. Again, I think clinicians may argue that this is just the path of least resistance. It's easier to give in to a family's request and to give in than to stand up for what's quote unquote right. Clinicians will also argue that, yes, we do have expertise with end of life. Therefore, I am an expert in treating your child as they are dying, and you should listen to my recommendation. And again, clinicians ought not abandon their duties to make recommendations and to be honest with patients and families. But I think by focusing on honoring the parent as a parent in that relationship, we can engender trust and alliance. Finally, provider moral distress is a very real issue, especially in the post-pandemic world where burnout is prevalent. And empiric evidence suggests that end-of-life issues related to quality of life, DNR decisions, conflicts over what's a patient's best interest really rank very highly as sources of moral distress, especially among ICU nurses. It's often linked to our perception of lack of benefit or futility. But I would argue that potentially non-beneficial interventions become beneficial when we shift our intentions. That if we find benefit in maintaining the relationship, that it doesn't have to be futile. Thank you, and then I'm going to pass it off to my next author.
I just want to add, I know you must all have some really pressing questions for Jenny, but the reason we did it this way, where we just present and then save questions for the end, is because we're essentially all talking about the same case. So Jane will come up, and we each have different accounts to explain and justify the clinician's actions in that case. And so I think there will be a lot of space here for interesting sort of conversations and overlap and conversations about where we differ and things like that. So.
All right, thanks everyone. So my name is Pierce Randall, and I'm at Albany Medical College, and the title of my talk is Respecting Familiar Relationships by Prioritizing the Need of Patients, a critique of the relational potential standard. And if you want to actually read the paper, you can use this QR code. It'll also show up at the end of the talk if you don't get it now. I have no conflicts of interest to disclose. So in this talk, I'm going to say a few things. I'm going to say a little bit about what's motivating me and how I arrived at this topic. I'm going to describe how I really think that there are two different relational potential standards here, ERIS's, and then the relational potential standard urged by Dr. Kingsley and Whiteman et al. I'm going to present a dilemma for the relational potential standard, or at least a positive formulation of it that I think undermines the case for it. And then I'm going to argue that respect for pluralism of different concepts of what it is to live a good life for a child can get us the result that advocates of the positive version of the relational potential standard want. So just some motivations that I have. I work in our consult service at Albany Medical Center, and we get a lot of seriously ill babies with conditions that significantly impact their cognition and their ability to relate to others. A lot of times these are babies with trisomy 13 or trisomy 18, and we get a lot of cases where providers are distressed because parents just say they want to do everything, right? And we say, well, we're not really benefiting these kids. Why are we doing this, right? So kind of this is the kind of case that, the Jane case that Dr. Kingsley described. I would say as ethicists, or at least in our service, it's kind of hard for us to say that providers are permitted just to ignore what these parents are asking for life-sustaining care. But it's also unclear, I think, for the reasons that Dr. Kingsley outlined, how we can really say that this kind of treatment is benefiting the patient. So the positive version of the relational potential standard is one way to describe the benefit of that. I'm going to try to give a different way of doing it. So I just want to lay out here that there are kind of degrees of cognitive impairment in babies that might bear on the relational potential standard. At the bottom end, the more impaired standard, sort of the limit condition, would be something like conditions that are just incompatible with any sort of conscious experience. So think about certain kinds of neural tube defects, like certain kinds of anencephaly. Moving up from that, you have kind of trisomy 13 and 18 cases. These are very common that we see in the NICU. And I kind of distinguish these. This is obviously not a perfect distinction between like survivable and I'd say non-survivable cases, by which I mean the kinds of cases where a child's very likely to expire in the first year. Often those patients are more cognitively impaired. And then I just want to put at the top here, because it's relevant to Eris's original version of the relational potential standard, many cases of Down syndrome often come with cognitive impairments, but it's nowhere near as severe as these other cases that we're describing here. And so may need not quite the same, they may not have the same kind of motivation for science like the RPS. So you probably have heard or probably know that in 1982, there were parents in Bloomington, Indiana, who refused life-saving care for a baby born with Down syndrome. And by the way, this decision was made on the advice of their doctor because the child had a cognitive impairment. This is controversial, and it led the Reagan administration and eventually Congress to establish the so-called baby doe rule, which prevents hospitals from discriminating against babies with cognitive abilities or disabilities when it comes to the provision of life-saving care. And this was intended specifically to respond to parental requests for non-treatment. Like the parents say, like, I don't want to treat my kid because they have a cognitive impairment. And this is supposed to prevent that from allowing the child, or to not, basically it's trying to prevent hospitals from accommodating the parental request. I would just note that today the debate is somewhat different. Today what we often see is that parents of babies with trisomy 13 and 18 that are significantly cognitively impaired request life-sustaining treatment for these babies, even against the advice of their doctors. So this is kind of the flip side of that case, and even you see sometimes like charges of so-called genetic discrimination against doctors for not wanting to treat babies in exactly these cases. So this is a picture of John Arras wearing a wonderful tie. And Aras's argument is that when we call something discriminatory, we usually mean that it's, we're treating someone differently than we would treat someone else on the basis of a morally arbitrary characteristics. It's not a basis for differential treatment. But a question you might ask is, like, is it morally arbitrary to say that life-saving or life-sustaining treatment isn't appropriate for an infant based on their severe cognitive impairment, like the baby doe rules ask us to do? And Aras proposed the relational potential standard as a way to explain why cognitive impairment is not a morally arbitrary basis to treat babies differently with respect to life-saving treatment. And this is a quote by Aras: "The presence or absence of such characteristics as the ability to think, communicate, give or receive love seem to be highly relevant from a moral point of view. Indeed, the absence of these capacities, is problematical in the extreme how we can attribute any human interest to the child on which the best interest standard may operate. When confronted with such cases, one wants to ask not whether such treatment will further the infant's best interest, but rather whether the child's impoverished level of existence is worth sustaining." So here's my attempt to formulate what Aras's standard is. He's saying it's inappropriate to apply the best interest standard to patients without the following distinctly human capabilities or capacities. First, the capacity for self-consciousness, and second, the capacity to relate to others. And he's saying that it's inappropriate to apply the best interest standard to minors who lack these capacities, and so false to say that it's somehow in these patients' interest to provide them with life-prolonging treatment. I will say, as an exegetical point, Aras seems unclear in both articles that I could find, Aras, about whether or not these are like individually necessary and jointly sufficient or what. It probably doesn't matter because they probably co-occur in most cases, but I just want to flag that. It wasn't clear to me. Now, you can contrast this with the positive version of the relational potential standard, which is defended by Whiteman et al. In a paper in 2019, and also defended by Kingsley and her co-authors in 2023. And this is intended to supplement the best interest standard and provide a reformulation of Aras's view. So rather than trying to promote the patient's interest in a narrow sense, clinical decision-making is supposed to aim at honoring the patient's capacity to be part of a loving relationship. So the emotions of the patient's family, their relationship of care to the patient, and the value they place in the patient's life can be the basis of clinical decision-making. And I should say, too, both of these papers locate this relational potential standard in a broader ethics of care, in case you're kind of interested in maybe somewhere this is coming from. So I might attempt to formulate this as something like this. There are at least some cases in which a minor patient has a cognitive impairment so seriously that it would significantly impact their ability to interact with the world, and so the quality of their potential conscious experience. Nevertheless, it is appropriate to honor parental or caregiver requests to sustain the lives of those patients. And the reason it's appropriate is because doing so honors and sustains the relationship the child has with their caregivers. For the interest of time, I'm not going to get into this, but I just have some observations that are kind of interesting about like what the relational potential standard, like is it a standard and stuff, but I'll leave that out for now. But one observation I do want to leave is you might wonder, like, are the negative and positive formulations of the relational potential standard even compatible, right? So let's say you're trying to apply Aras's view, the negative formulation of the relational potential standard. You ask, like, does the patient have those two capacities that we listed from Aras? Well, if they do, then it sounds sounds like Eris is saying you should apply the best interest standard. And then you wouldn't need the positive formulation of the relational potential standard. It wouldn't come up. Conversely, if you follow Eris's view and you say, well, the patient doesn't have those two capacities, then you would say that the patient has no human interest in being kept alive. So it would be inappropriate to apply the positive formulation of the relational potential standard there. So I just want to flag that these are like two different standards here so that we don't conflate them. So this is the main part of my argument. It's really a dilemma for the positive formulation of the relational potential standard. Are care decisions that honor and sustain the patient's relationship with caregivers or parents supposed to be good for the patient or not? So is the relational potential standard saying this is good for the patient, or is it saying this is just good for the family? If the claim is that it's also good for the patient, then I think that's fine. I think that's a very nice view. But I think then the best interest standard could explain why we should honor those relationships, and we don't need the positive formulation of the relational potential standard. If it doesn't say that, which I take it this is the no option here is the right way to read the view, then I would just say it's ethically unappealing, it's ethically objectionable. We're doing something to the patient's body for some set of interest or values other than the patient's, and I just think that's bad. So this, if you go with the yes option here, I think there's a lot of good things to be said for this. It's to say that honoring a loving relationship that a patient is part of is in the patient's interest. And I think this is a very good view. Like, I think I agree substantively with Dr. Kingsley in a lot of these cases. I think it captures the intuition a lot of people have that being part of a loving relationship is good for someone. So if I ever find myself alive with a severe cognitive impairment, whether or not I want to be alive, whether or not I have the ability to recognize my loved ones, I hope I'm still part of a relationship that involves me being loved, even if that relationship is largely one way. And I think I have an interest in that. A problem, though, with this interpretation is that we might want an account of why that intuition is true, like why is so good for the patient about being loved if they can't experience it, and the view might need something like that. Also, this would take some of the motivation out of the sales of having a separate standard, because I would think that the best interest standard could account for the value of being in a loving relationship if it is good for the person, even if they don't experience it. But I actually think the right way to read the view is the no option. So suppose the view is that clinical decisions should be made the clinical decisions should be made to extend the patient's life, not because this is in any way the interest of the patient, but because it's in the interest of the patient's family or because it honors the loving relationship they're a part of. And understood this way, I think the view is much less appealing. It says since we can't apply the best interest standard because we can't locate a rationale for clinical decision making in some set of interests the patient has, which is what we would normally do in this case, we should just look elsewhere for some separate value to promote or honor. Now, I do want to say that the best interest standard, there's a lot written about it. I don't want to wade too much into some of the deficiencies of it. I would say that, though, that there's two senses in which the best interest standard is a standard, and I think most of the discussion about it talks about this first sense, which I'm not going to wade into. But I think really interesting that the best interest standard is actually the second sense. So the first sense in which it's a standard is it provides us with a set of deliberative criteria. It lists a potentially incomplete set of considerations that we might appeal to when making clinical decisions on behalf of a patient. So we might look at certain things like prolonging a patient's life or avoiding suffering or restoring more normal bodily function as a set of like good things that we can try to promote. We should get the best outcome we can along those criteria for the patient. But I also think more important in the best interest standard is what I'm going to call an exclusionary criterion. This establishes considerations that should not be appealed to in making clinical decisions. In the case of the best interest standard, that is other people's interest, at least when they're no way connected to the patient's interest. So this is analogous to what Joseph Raz, a political philosopher, sometimes calls like exclusionary reasons. I think that following the best interest standard gives you an exclusionary reason to not consider other things as reasons for a clinical decision. And I actually think that's what's good about the best interest standard. This can explain why other considerations don't apply to clinical decision-making. For example, suppose we were to consider things like social utility or the interests of providers when we make clinical decisions. Why should we stop at promoting the interests of the family when there are lots of other interests that we could try to pursue in clinical decision-making? As we heard, concerns about provider distress are very important, right? And if we can't do anything to maximize the patient's best interest, why not just make clinical decisions directly to promote things like that? Or why not promote things like social social utility, like what's the least costly option to society for treating a patient. And we normally wouldn't want those kinds of considerations to be brought to bear directly in clinical decision-making on behalf of a patient. That's one thought too many, right? Like the patient's interests are what matter. This also helps explain why the doctor-patient and surrogate relationships are a fiduciary relationship. It's important to the value that they have as fiduciary relationships that the doctors and surrogates are making decisions on behalf of a principal, the patient. And I think the positive formulation of the relational potential standard asks us to give that up. So in the interest of time, I'm not going to go too much into these objections, but if you want, we can talk about them in the panels. Also, these are discussed more at length in the paper, but basically I don't think I'm making a mere means objection, as Dr. Kingsley included in her talk and in her paper. I don't think my view is grounded in Kantian ethics or anything like that. There's some interesting things to say about, like, can you delay extubation by like 1 day so the patient's family can be with them before they die? If you want, I'm going to bite the bullet on that probably, so if you want, that might be a good objection to talk about. So I'm going to describe my alternative view, which I call reasonable pluralism or respect for reasonable pluralism. So I think Aris, Kingsley et al., and Whiteman et al. Are all carving out a space of permissible deference to parents regarding the provision or withdrawal of life-sustaining treatment. And they do this by providing potential justifications for these decisions. So if you listen to Aris, a parent might be justified in requesting that life-saving treatment be withheld from the cognitively impaired baby if that baby lacks the capacity to relate to others, because then the best interest standard doesn't apply. So it's an argument for the justifiability of that decision. If you follow Whiteman et al. And Kingsley et al., a parent might be justified in requesting life-sustaining treatment for their severely cognitively impaired child, not because doing so promotes the best interests of the child, but because doing so would honor and sustain the loving relationship parents have with the baby. And I think a better strategy than trying to provide a direct justification for these choices is to offer a justification for deferring to the parents in the first place. So I would say the axiology, the idea of what is a good-making feature of life, is not an exact science. We lack any kind of social or expert consensus about what gives life value. Some people might say that, for example, the capacity for cognitive experience is a necessary condition for someone's life to be good for them, and therefore for them to have interest. I mean, after all, if you don't experience your life as good for you, how can it be good for you? But I would say there's no consensus on this point. Some may say that life is a gift from God, and that people have a soul, and that being someone's son or daughter could be good for them, even if they're not aware that they're someone's son or daughter. So it seems like we just have a lot of disagreement about what's good about someone's life. Aris in 1985 is an interesting observation. He says that ethicists sometimes conflate two different questions. You may think that I'm doing this here. One question is who should decide for a baby? And second, what should they decide? And sometimes we want an answer to B, like we want an answer to like what should be done for this baby, but we substitute for it an answer for A. So that we are saying essentially the right decision for this baby is just whatever their parents decide. Following Rawls' in Theory of Justice, Aris calls this, or he likens this to pure procedural justice. We think a given decision or outcome is justified so long as the appropriate procedure was used to produce it, in this case the procedure being ask the parents. But I would say that respect for pluralism, in my view, is not an anything-goes approach. It's compatible with the view that there is a right answer about what's in the child's interest. Rather, respect for pluralism acknowledges that there's just wide disagreement about what that answer is, and we don't have a consensus on it, so we're better off deferring to parents. The case for parental discretion is not based on the idea that parents will tend to make the right choices for their patients, just that they're no less likely to make the right choices than doctors, ethics committees, state agencies, or court-appointed guardians in these cases. This is actually more akin to Rawls' idea of imperfect procedural justice, where there is, or at least might be, a right answer, but the procedure we use to arrive at it will not always get it right. The procedure is justified just in case it's the best procedure we have available, or at least it's not decidedly worse than any alternative. So if you wonder why I have a picture of, I guess, 13 angry men here, Winston Churchill famously said democracy is the worst system other than all the alternatives. It's sometimes described as the Churchillian shrug for the justification for democracy. You might say I'm giving a similar point about parental deference, not that parents always get it right, but just like it's the least worst option we have. An example of imperfect procedural justice would be something like a jury trial in the United States, obviously well known that they're imperfect, it's a procedure, but we don't have an obviously better system for deciding guilt or innocence of crime. Any view according to which we should defer to parental decision-making needs to be constrained in some way, right? It's like if parents just assert anything is in the interest of their child. Recall in the original Baby Doe case, parents wanted to refuse care because their baby had Down syndrome. Would we feel comfortable honoring that refusal today? The life like that is not worth living for the child at all. So the constraint I would propose is that parental decision-making should be reasonable, right? So it's just not any kind of pluralism. It needs to be bound by reasonableness. Okay, so you might be worried, like, reasonableness is the last refuge of scoundrels in philosophy and law, and maybe this idea is not so promising. The idea of what's reasonable is vague, perhaps it lacks substance, maybe it's just my attempt to give like a hand-wavy gesture at some other unspecified set of values. But to put some substance on the idea, I'm not going to give you a full account of reasonable pluralism, but to put some substance on the idea, I propose one criterion by which a parental request is reasonable. It doesn't involve radical discounting. So I would say there's certain aspects about life about which there is broad agreement that they make life better. Pleasure, the absence of pain, the quality, quantity, and complexity of conscious experience. And I would say that none of these should be wholly discounted in reasonable decision-making on behalf of a child. So if parents were to say something like this, I would take any amount of suffering to spend 1 extra minute with my baby. Or if they were to say, I don't care how happy a life of a child with Down syndrome can be, I don't want my child to live a life with a cognitive impairment, I would say that these are unreasonable requests because they radically discount features about which there is a consensus that gives human life value. Essentially, they're saying, I put no value on the suffering of my child, right? And that's unreasonable, even if we would accept a large degree of pluralism about what it might be reasonable as a request. However, I would say some parents may believe that it's in the interest of their child with a severe cognitive disability to be part of a loving, familiar relationship, even if the child is not conscious of being in that relationship. And I think requests for care made on the basis of this belief can be reasonable, so long as they do not discount other less controversial values like the avoidance of suffering. For example, you wouldn't honor refusals of pain management just to maximally prolong life for a child. Other criteria might be used here as well, although I don't talk about in the paper. For example, maybe you need something like a criterion like consistency. If the parents are saying a relationship with my child is important, but they never visit the child, that might be some evidence that their insistence on life-saving care is not reasonable in that case. But I won't get into that. Anyway, that's my time. Here are my references. If you like the paper, you can use this or QR scanner.
What did I do? Oh, is there a separate document?
Just X out.
Oh, I see.
And then you can close that too. And then.
Okay. All right, my name is Xiang Yu. This is something that Daniel and I have been working on together, and we're excited to share this work with you all, and we very much look forward to getting your feedback on it. When deciding whether to sustain the life of a child, we think that the key question to ask is this child's life worth sustaining? This is a question that Aris asks in his 1984 paper. We think this is an important question to ask, and we're inspired by his question, and we want to propose a meaningfulness standard that's different from the best interest standard and then the relational potential standard. We have no conflicts of interest to disclose. And here's the agenda for the presentation. I'll introduce Aris' critique of the best interest standard, which motivates him to ask the question about meaning and worth. And then I'll say a few things about Pierce's proposal. And after that, Daniel will discuss the concept of bestowed worth and propose our meaningfulness standard that's based on that concept. Okay, let's take a look at Aris' critique of the best interest standard. He invites us to imagine this kind of scenario where the child suffers no pain, he lies there in his crib, blind, deaf, and uncomprehending. Never having experienced the satisfaction of normalcy, the infant is neither horrified by his plight nor depressed by the thought of his impending doom. He just lies there. And if that case is too abstract, we can maybe think about a case of Jane that Jenny introduced earlier. So this best interest standard would ask, is it in Jane's best interest to die or to live? Jane, it sounds like Jane presumably has interest in not having too much pain or suffering, but if that's managed, then it's difficult to understand what other interests that Jane could possibly have. So the default decision seems to be often an indiscriminate mandate to treat the child and to keep the child alive, which Aris thinks seems to go against common sense. And so he thinks that instead of asking the question of what's in the child's best interest to do, what needs to be asked is the child's life worth prolonging? We think this is a very important question to ask, and it's something that clinicians often do ask themselves. And when pursuing aggressive life-sustaining treatments for such children, it's natural for clinicians to ask, is the life that I'm sustaining worth sustaining such that my efforts are meaningful? And this is not an abstract question for them. It's very much personal because they are actively participating in what's happening and they are morally distressed. We want to approach this issue from the perspective of the clinician because it's the clinician who must order the aggressive treatments on a profoundly vulnerable child. And the ethical resolution on the question should be something that society can rightfully ask of clinicians and builds on their moral experience and concerns. I'm going to say a few things about Pierce's proposal that we should, because of the problems with because of the dilemma that the RPS faces, we should default back to the best interest standard. One challenge that this proposal faces is that it seems to assume that parents have access to some special knowledge about their child's interests that others do not. But this is frequently not the case, especially if the imperiled infants have not had a long history with their parents, or if the family are rarely seen at the bedside, and the care team often have spent a lot of time with the child, and they have expertise in taking care of children with similar conditions. And moreover, we think that this suggestion leaves the care team where it started. Proponents of the relational potential standard are motivated by the concern that it's difficult to know what a child's interests are when they suffer from a profound cognitive impairment or are at the end of their life. Defaulting back to the best interest standard doesn't give clinicians a better sense of the child's interests. And lastly, and most importantly, we think that relying on the best interest standard fails to recognize that a child whose profound cognitive impairment deprives of them of any potential for having the capacity to participate in a care relationship cannot have interest in that relationship. We think that the capacity for relationship would involve things like being able to be aware of oneself and others, to take pleasure in another's company, and to show affection toward others. And it seems that a child who never had or will be able to have these experiences doesn't have interest in these experiences. One objection to this last point is that what if we accept a view about well-being that's objectivist kind of view, which says that there are some welfare goods such as knowledge, achievements, and loving relationships in which all human beings have an interest in, regardless of their actual capacity for it. And according to objective theories of well-being, some things are intrinsically good for a person in the welfare sense, regardless of whether the person enjoys it, likes it, wants it, or approves of it. So for example, a person who doesn't enjoy being part of a loving relationship or may even feel harmed by it still in fact benefits from the relationship because of the kind of a creature a human being is. And therefore, this objection says that if we accept an objective theory of well-being, then we might be able to say that a child whose profound cognitive impairment deprives them of any potential for relational capacity can still benefit from the parent-child relationship. However, we want to point out that even welfare objectivists think that a person must be able to have certain capacities to benefit from a loving relationship. For example, Christopher Rice, a welfare objectivist, argues that loving relationships benefit a person not because people want to have them, but because love is reciprocated in such a relationship. And for reciprocity to be possible in a loving relationship, they require that the person desire the good of another and take pleasure in that person's company. Guy Fletcher, another welfare objectivist, holds a similar view, and he thinks that all intrinsic goods must involve the person's engagement through her holding various kinds of pro-attitudes such as endorsements, desires, and affection. Otherwise, the person cannot benefit from the good. So this means that if a child doesn't have any desires, feel any pleasure, or endorse their loved ones in some way, then it seems like they fail to benefit from being in a loving relationship. Therefore, appealing to objective theories of well-being doesn't entitle one to say that a child with profound cognitive impairments can derive interest from being in a loving relationship. Thank you.
All right, thanks, Yang. So given these challenges for BIS and RPS that Xiang has laid out and we've been discussing in this panel, Xiang and I basically wanted to propose an alternative way to make sense of a clinician's obligation to continue life-sustaining treatments for a child like Jane. So to do that, we turn to this idea of bestowed worth. Now we're getting this concept from Nicholas Wolterstorff in his book, Justice, Rights, and Wrongs. He actually uses the concept as a way to ground human worth or human dignity. But for the sake of time, we won't go into his detailed arguments there. But we just want you to be aware of the context in which this idea is being developed. But basically, for our purposes, the claim of bestowed worth comes down to the idea that being loved bestows worth, and in our case, on a child. Now, not any kind of love will do this, right? Only love as attachment does this, according to Wolterstorff, and this is different from love as attraction and love as benevolence. So, for example, Rembrandt painting is beautiful, it has lots of artistic merit, and it attracts you, right? You love it. But you loving it doesn't bestow worth on it. It already has a worth that you love in it. So that doesn't bestow worth. With love as benevolence, if you, let's say, feed an emaciated pet, say a dog, so that it becomes plump and more cute, you've given it a different kind of worth. But what gives it worth there is a change that you brought about by feeding it, not by your love per se. So that also doesn't bestow worth. So according to Wolterstorff, only love as attachment bestows worth. To the whole world, Jane may look sickly and burdensome, but to her parent, none of that matters. Right? She's loved unconditionally in the mode of attachment. The parent is just attached to the child, come what may, regardless of how beautiful or useful she is or isn't. And this is, according to Wolterstorff, the kind of love that bestows worth. Now, the worth this love bestows inheres in the person. So Jane has a distinctive worth as someone who is unconditionally beloved by her parent in this way. It's a part of Jane's identity. It's who she is. She's a being of this sort. And so this is her worth that we are talking about, not the worth of the parents. Now, how does this happen? Right? Wolterstorff doesn't provide an elaborate philosophical account of how this works. He acknowledges that it's mysterious to some extent, but he argues that it's very common and recognizable. So relics or heirlooms are easy examples. Right? There are objects that have a distinctive worth, not because they're necessarily beautiful or expensive, but because they're tied to someone we love or honor in some way. So we're at a museum, we have a museum full of these things, right? Or in our homes as well. Now, of course, an heirloom is a thing, not a person. So you can't necessarily wrong an heirloom. Ruining it, say maliciously, would be wrong only because it's it would demean the owner of the heirloom or the memory of the person it belonged to, not the heirloom itself. But there are other cases where we recognize the worth that a person has by being beloved. Now, the example that Wolterstorff gives is a person who's befriended by the queen. Let's call her Mary, right? And the queen loves her in the mode of attachment. She gives Mary a distinctive worth as a friend of the queen. Now, we can see this new worth that Mary has in two ways. One, she is now a source of other people's envy. Right? So even if the queen were not to reward Mary with any riches or titles, many would still envy the simple fact that she's the queen's beloved friend. Secondly, Mary would rightly be offended if her worth as the queen's friend were demeaned. So if I were to dismissively say, big deal, right, and mock the value of her friendship with the queen, Mary would be offended. She'd be offended not only because I'm indirectly demeaning the queen, but also because I'm demeaning who she is. So again, the point here is that the worth that is bestowed inheres in Mary is part of who she is, and to demean that worth would be to demean her. So getting back to the question of the worth of a child's life, our claim is that parental love in the mode of attachment imparts distinctive worth on that life. And this worth, depending on its distinctiveness, can entail differential treatment. So if the worth of Jane's life is one that should be prolonged, then not providing that treatment would be to disrespect that life. It's also worth noting that parental love is not the only source of Jane's worth. That's not what we're claiming here. I can mention two other sources of worth that are important. So one is that Jane has a basic worth as a human being. So whether she's loved in this way or not, or whether she even has parents, has no bearing on her inviolable worth as a human being. Now, another source of worth for a child would be their interests or capacities. Right? So a child who has potential for rationality or relationality has a distinctive worth that we need to respect. But of course, in Jane's case, the point is that she lacks any such interests or capacities and is not expected to have any. And in that case, our claim is that her parents' love for her can be an additional source of her distinctive worth. Now, with bestowed worth in mind, we get to the meaningfulness standard. So are my efforts meaningful? This is the clinician's question that we started our presentation with. And I think most of us would agree that for some activity to be meaningful, it needs to be both personally fulfilling and worthwhile. Right? So for clinicians, keeping someone alive is presumably fulfilling, right? They swear an oath to do this, and this is what they want to do. They want to do this. But whether keeping someone alive is meaningful also crucially depends on whether the child's life is worth keeping alive, whether it should be kept alive. So the meaningfulness standard tries to address this question of worthwhileness. And the basic question is this: would prolonging this child's life serve her interests or capacities or be properly expressive of her worth? And this latter consideration, of course, is what our idea of bestowed worth adds. Now, on this standard, if the answer to this question is yes, then the treatments should continue, and if the answer is no, then they should stop. But you may be wondering, is the worth real, right? Or is the worth of Jane's life based purely on the parent's subjective whim, no matter how diluted that may be? Well, first, we'd say that there can't be objective certainty about the valuation of any child's life. The value of a life is not some empirical fact that's out there and that we can observe and measure. The worth of a child's life is indeed inextricable from our interpretation and valuation of it. But second, this is not to say that the valuation is subjective all the way down. A more perspicuous, clearer account of that worth is possible. So for example, a parent may eventually realize that they've now done everything possible to advocate for and affirm their child's profound worth. This would be a movement on the child's parents' part toward a clearer understanding of what their child worth requires. The same movement could happen in the clinician, where the clinician is moved by the profound love of the parent and concludes that, they're not unreasonable to value the child's life in that way. Now, this kind of mutual growth toward more clarity about the child's worth seems entirely possible. We believe should be encouraged, and I think we see it all the time. But for this to make sense, of course, we need to posit that the child's life has some objective worth that a parent or clinician can be mistaken about and debate over. Even if we can never know for sure, we at least need to presume that the worth of a child's life is not subjective all the way down. Now, in practice, this idea of growth toward more clarity about the worth of this child's life would recommend something like a shared decision-making approach that John Lantos, for example, has written very well about. It's a process of decision-making in which clinicians seek to clarify values rather than merely provide information for parents to deal with. Now, given the lack of time, I'll not say more on this, but you can certainly read more in Lantos's NEJM article from 2018, pictured here. Lastly, some potential concerns. So we'd argue that we avoid Pierce's two critiques of the RPS. The question of what's properly expressive of the worth of a child's life is not an issue just of the child's interests. It can't be reduced to a calculus of BIS because a child can have worth that, even if she lacks any capacity to realize any interests. Bestowed worth also doesn't violate the exclusionary criterion. It is about respecting Jane's worth, who she is as a beloved child. It isn't about the worth of a parent-child relationship. Also, are there any limits to what's properly expressive of a child's worth, or does anything go? And our answer would be no. Specifically, decisions that demean the worth of the child that love bestows would be inappropriate. So wanton harm would not be loving, right? It would demean the child and her humanity. Parental self-interest would also not be loving. So the decision, the parent deciding that for some psychosocial benefit to themselves would not be a loving act. The decision must instead be grounded in evaluation of the child's worth, not the interests of the parents. Okay, to conclude, now to be sure, the guidance that a meaningfulness standard suggests are not different from what BIS or RPS might suggest. But what we've tried to do is provide a positive account of why a clinician's obligation to continue life-sustaining treatments is meaningful, even if the child seems to lack any interests or capacities. And in that way, we hope that it might help alleviate some of the moral distress that clinicians might feel. Okay, so that's the end of our talk. So we'll move into a time of panel discussion. I know we've sort of set out some differences within our views and critiqued each other, but I promise we're not necessarily in competition here. Our conversations thus far have been really constructive. We recognize that this is a really difficult case, difficult challenge, and we're all sort of struggling to try to better articulate why this tends to be the consensus ethics recommendation and whether it should be. And so essentially, we would invite you to join us in this sort of struggle, and we're trying to build each other up here. And so just to help us along, so please feel free to ask questions directly to a particular presenter if you want clarification on their specific view. But just to sort of help us make sense of all the different views that have been presented, so you've seen sort of 4 views, right? Eris, he's absent, but his view, he started off this conversation for us, and his view, of course, is the relational potential standard. And the key question for him is, does the child have a capacity for relational potential? And the justification in asking that question is, a life without a relational capacity is not worth living. Now, Kingsley, Jenny, another version of relational potential standard, and the key question for her is the child part of a loving, caring relationship? And this is an important question because familial relationships have inherent value that clinicians may be obligated to respect. And then, or promote even. And then with Rand Pierce, best interest standard, he wants to essentially rescue that. And the key question for him is what's in the child's best interest? And the justification, interests of others should be excluded from clinical decisions for the child, so it's really important to focus on the child's best interest. And then for myself and Xiang, the meaningfulness standard, the key question is sustaining the child's life a meaningful, worthwhile act? And the justification would be that parental love can bestow worth even if the child lacks interests or capacities. All right, with that, we can open it up for questions. I believe Liviu has a mic that he'll carry around. Yeah, Alexi.
Thank you all for your presentations. One perspective that I found very interesting that seemed to be missing from all of your arguments, but was hinted at in the first presentation, was the moral role of the physician. So there's a couple pediatric surgeons, for example, in my row here, and we get asked to do things that are very invasive and cause enormous amounts of harm to children. And we typically don't think about like reasonableness or meaningfulness. I think often we default to like the level of risk for perceived benefit. So the case study, had you asked me to put that child on ECMO, they're coding, ECPR, come to the bed. How would we like think about that? And then what sort of moral consequences exist for the providers who are doing that harm? I have to go home now after what some may say assaulting this child and live with myself, right? So thinking about moral distress, right? And this is a big deal for example, a lot of our nursing colleagues who choose to relocate to other parts of the hospital where they're not asked to do these sorts of things. So, and I get this gets into some like omission and commission bias and whose hands are doing the things, but I'm curious if you could comment on the moral nature of the commission, of the invasiveness of the thing you're asking us to do. It's one thing to say like, I mean, you could imagine a scenario, a kid's plugged in, like is on like some set of machine, it's plugged into the wall, nobody's touching it, you know, we're not going to withdraw. But what about like the invasiveness and the ask of the person? So in that triangle, to what extent does the person doing the harm to benefit the parents and the relational potential standard, to promote the pluralism, the reasonable pluralism, or to honor the parents' view of meaningfulness, what role does that play? Because I'm guessing we would use the language of that child you presented is not a candidate for transplant. They're not a candidate for ECMO. Why? Is it because it's unreasonable? Is it because of the level of harm? Is it because of what you're asking the provider to do? Right, it's one thing to jump in front of a bus to save someone. It's another thing if I push Daniel in front of a bus to save someone else. Those are maybe morally different. So anyways, thank you for great presentations. Love to hear your response to that.
So this one is good. Maybe we can share.
I just don't know how to turn a mic on. So I think your question is, for me personally, is what motivated starting to think about this question, because I was a fellow in the ICU walking around directing my nursing colleagues to start CPR and dealing with the emotional aftermath. And in some of these conversations started to really feel, and this is how I personally feel as a clinician, is that if I can, within some bounds, as you recognize, like I, as an ECMO consultant, agree would not be an ECMO candidate. But because we don't have a bridge to anything, right? If we're certain this patient's going to die. But I genuinely feel that if I can better align my efforts with an outcome or with a request of a family member that is going to leave this hospital without their child, that I feel that I've contributed to good. And I recognize that people feel that I'm throwing the child under the bus in that situation. But that's where I think some of the bounds of excellent pain management, sedation, those things go hand in hand with what I'm talking about. And what I find is when I really start to engage our nurses about what we're doing and who we're doing it for, the intention shifts. When the intention shifts, the feelings shift. I don't have a study to back that up, but that's been my anecdotal boots on the ground experience. I think it's interesting. I've noticed a difference in approach between medical providers, I think, in the ICU and sometimes our surgical colleagues, and how they weigh these decisions. And I've wondered about that as well. Like I don't know if it's because there's your hands are physically doing the thing. It's hard for me to go all the way to assault with a patient in the provision of medical care when you have consenting parents, but I recognize that there is a difference, and I haven't totally wrapped my head around it.
I can also respond if you want. Yeah, so just in terms of how to think of it, I would just maybe speak for myself. So I think that you mentioned like the risks and benefits of a procedure. And we might say that like a patient like Jane is not a candidate for ECMO because the benefits won't outweigh the risks. The risks in question, I think, are kind of uncontroversial here. And I think everyone on this panel agrees that like Jane's suffering would be a reason not to do it, right? What we disagree about is like what kinds of benefits one might appeal to in deciding whether or not ECMO is supportable or not, right? So I think on Kingsley's view, for example, and also Whiteman's view, and maybe Aris would go in for something like this, like the relationship, honoring the relationship the parents have to the kid would be a kind of benefit that you could promote. I think one thing that that Jenny could say about why ECMO might not be appropriate, but other life-saving treatment might be, is that ECMO might preclude your ability to like really relate to someone else, because like that's just you're somewhere stuck on machines the whole time, and you're really in an ICU somewhere, or not ICU, like wherever you are with that intervention, and so not saying where you can like spend a lot of time with your parents. Kids aren't going to be held, stuff like that, right? I guess on my view, we should just need to be somewhat pluralistic about what kinds of benefits parents might want to achieve in different kinds of care. I think that we might be able to say in a lot of cases that if the suffering's great enough, there really isn't a route whereby the parents can reasonably say that the benefits they're trying to achieve outweigh the substantial amount of suffering they're getting without radically discounting suffering, which on my view would be unreasonable. Regarding provider distress and how we might process that, I think the answer to provider distress in these cases is also the honest one, right? In that you're providing care, you're not sure if it's good for the baby or not. And what you can say for yourself is like, well, I'm not really in a better position to know what's good for this baby than the parents are, because that raises deep philosophical, like value-based questions about which there really just isn't a consensus. And so I hope, that won't completely alleviate the distress, because anytime you're making decisions with children and their parents are making decisions that don't seem like they're in their best interest from your point of view, that's going to be distressing. Like public school education is distressing, right? Because like a lot of teachers experience exactly this in interacting with children. But still, I think like the answer, what you have to tell yourself every day is like, it's the decisions the parents are making. I'm not really better situated than they are to know that those are not right ones for the kid. So
it's not clear to me why you are so okay with ECMO not being offered, but intubation and CPR, right? Like, they're just gradations. Both would sustain life for a set period of time. They're not going to save the child ultimately, right? So is it the invasiveness, how expensive, or like, how do we draw, like, when does gray become black, if that makes sense?
yeah. I appreciate that concern, and I think that's something that probably maybe all of our papers would benefit from, is this more granular discussion. Sorry, I don't mean to speak for everyone else, but maybe as my view, and I would say mine does, about like how we decide for particular decisions. I'm just trying to give you like a sort of framework of values, but yeah, you're right, like knowing exactly.
In my paper, if you read that.
Sorry.
No.
Yeah.
Yeah, and just to underline something that Pierre said, I think all of our accounts depend on the idea that we are not, in fact, harming the child, in the sense, I mean, it may feel that way, may feel like you're assaulting, but presumably they're not feeling any kind of pain or suffering. Certainly when you talk to clinicians, there usually isn't a positive account saying that they are in fact suffering. It's usually, we don't know for sure. But I mean, to the extent that they're not in pain, we would, I mean, basically we're presupposing that we're not harming. But I really do love the way you asked the question, and that's, for us anyway, for Xiang and myself, that's why we call it sort of the meaningfulness standard. We're thinking from the perspective of the clinician, is this a meaningful act? And we're hoping that just sort of seeing the bestowed worth that this child has, that's why we sort of ended saying that it's sort of a positive account for the value that this child has, such that keeping this child alive is in fact meaningful, presuming that there's no harm being done, and that's sort of neutral.
I'm just going to quickly add one thing. I feel like there's maybe one question about, like, should I sustain the life of this child? And then there's maybe another question about, is this going to be a regrettable action? I guess it could be that there are some cases where sustaining the life of the child is the right thing to do, but you also end up feeling regrets and distress afterwards. So I guess that's just like a theoretical distinction. Maybe it doesn't. Maybe it's unsatisfying, but maybe that's what we have to live with in some cases.
Yeah, thanks for 3 really great presentations. My question is actually somewhat related to the last one that was asked, but this is this question is more for Dr. Kingsley. So you mentioned that, and this is a sort of well-known critique of the BIS, that there's a sort of basic difficulty in defining the best in best interests, and I think that's fair enough, and it's a plausible critique. When you were answering objections, especially the first objection, you said something like, well, yes, true, this proposal has a potential for licensing harm, and so for violating the duty of non-maleficence, but then we sort of have to add a kind of analog of Mill's harm principle. Huge fan of Mill's harm principle. I'm just wondering whether the sword you used against the BIS cuts against the harm principle, because we could just turn around and say, well, yeah, who's to define what's harmful? There are many reasonable interpretations of what harm involves, and so I like this move, but I'm wondering how you would deal with that sort of objection.
Oh, I think that's a great objection. I don't know that I have any. Yeah, no,
Okay.
I think we have to recognize, in the same way that suffering, I think harm, it can be a subjective term, and so I think I don't have a great answer for that. I think that's a great objection. I think. The other thing that I want to say is I think underlying all of this is, I and I don't know how you guys feel about this, but just a degree of humility about all of these things, right? About what constitutes harm, what constitutes worthwhileness, what constitutes meaning. And I think where I sometimes feel like I get stuck, especially with my clinician colleagues, is a lack of humility about what some of these things mean, and a lack of humility about the pluralism. And so, how to move the needle on that, I think, is really hard. But I think that applies to harm as well.
Yeah. Thank you.
Yeah.
Thank you. I'm Bill Dirch, a surgeon at Northwestern. Thank you all for the fantastic talks. It's a terribly hard issue, and not just in pediatrics. But I would say that, very frequently excluding the interests of others is not what we do. I mean, not a lot of people here would take too much of a qualm with waiting a few hours for family members to arrive, waiting a day as somebody's on life support for them to make that decision. And then it starts to get into a quandary when we start asking, interventions that are more harm-based. And that really gets into the granularity to the previous question of, where is the gradation? And I feel that, many times, often I think we spend, despite having the fiduciary relationship with the patient, we spend a great deal of time, potentially vastly more time, with the family members, with the other people who have relationships with the patient, than with the actual patient, right? They're on life support, you maybe do an exam, you check the chart, but the vast majority of the time is spent discussing and exploring the relationships and the values that patient or that family member has with the patients. So the question is, how are we reconciling those relationships and those relationship values with the best interests of the patient, rather than excluding one side or excluding the other side? And while I agree, I very commonly, I would have a lot less hold up taking a patient to put a ventriculostomy in a low benefit situation than doing a craniectomy. Why is that the gradation we choose? Why is it not, how do we reconcile that?
I think I'll take a stab at answering that, partly because I think that's a pretty good objection from my view, right? Because my view is saying you only consider the patient's interest. Okay, so in the paper version of the talk, I describe okay, say you have a patient that are persistent vegetative state. Maybe they've never attained a certain degree of cognition such that they would be able to recognize their family or anything like that. They're on a ventilator right now, and it's medically appropriate to extubate them. I guess we're going to say the ventilator's not doing them any medical good anymore. And the mother is 1 day away. So do we want to insist on principles? Do we want to go in for a severe morality to say if you wait a day to extubate the patient, there's no benefit to the patient for waiting a day. It's just a benefit to the patient's mother. So does that mean that we just need to extubate now? And is that not monstrous? Is that not disrespectful of basic human relationships? And I think I would make two moves here. So first of all, I think my view actually has resources to deny the assumption and the point, because recall that my view is that we should accord substantial pluralism when parents assert that it's in the interest of their child to say live an extra day. So the mother were to say, look, I know my baby won't recognize me or my child won't recognize me, but I still think it's good for them to be with their mother when they die. I would be inclined to say that that's a reasonable assertion that someone could make. I hope that even if I'm not conscious that my loved ones are there when I die, right? I think most people hope that, so I don't think that's unreasonable at all. So that's one move I would make, and that would be my move to say we aren't just treating the family, we're treating the patient there. And that's a deep understanding of what the good of a person is, that maybe the parents are insightful, have insight to, and maybe it isn't so apparent when we only look at the patient as a monad, they're just an individual without thinking about their relationships. I would say that another move I would make if we wanted to deny that, just insist there's no way this is good for the patient, or say you just don't agree with my reasonable pluralism case, but you still want to press my point about the best interest standards exclusionary reason, I would say, I guess I would bite the bullet and say that like that is not applying the best interest standard. But if I were to put in that position, I would say the best interest standard might be a pro tanto principle, and there might be all things considered reasons to maybe not act on the pro tanto principle. So at least there's a residual here. There's something wrong about it, right? Like you're using the person's body to satisfy their mother. But maybe sometimes there's all things considered reason to do things that would otherwise violate the best interest standard. It's going to be weird cases, like imagine there's a natural disaster and providers have to flee for their own safety, leaving their patients at risk. It's like, I don't want to say that like that's never justified, but there's something wrong about it. You're abandoning the patient, right? So that's what I would say in those cases.
And then we can jump in. I think the scenario, I mean, this is perfect for Jenny, right? In terms of, I mean, she'd be very comfortable with this and biting the bullet and saying we should, give due consideration to the family. Hope I'm representing your view correctly there. But like from our perspective, I think we would also be willing to sort of accommodate that, just in the sense that the question for us would be, what does the worth of this child require? What would it mean to respect the worth of this child? And if that worth entails, the worth of that child entails that the family be able to gather and, say their goodbyes and things like that, that would be okay on that account. And I think that's how we would try to reconcile. But that would be the key question. But what it means to honor the worth of this child's life.
Do we have time for more?
Yeah, maybe time for one more question. 5:29.
Thank you all so much. It's really super interesting stuff. So my questions come actually from two cases. Obviously, a lot of these seem to be sort of grounded in sort of U.S. And I think a lot about sort of like the Charlie Gard and the Indy Gregory sort of cases that are going on in the U.K. And my question is sort of on the issue of the issues of the sort of the standards for transfer. So in both of those cases, what's involved there is a conflict not between the providers think this what we're doing for this patient is not beneficial and potentially harmful, and the parents are not requesting for them to provide that. They're rather to be released so that in the case of Charlie Gard, he can go to the U.S. and get some experimental nucleoside treatment, and in the case of Indy Gregory, for her to be released to go to a hospital in the Vatican to get some really involved, if I remember correctly, like heart surgery and some other things that were potentially potentially inappropriate. Now, to me, the questions that y'all are focusing on are sort of the questions about sort of the providers, are they obligated to do these things? Here, it seems like the standard for transfer seems to be a lot lower. That like these providers might think like these are not beneficial, but I'm not so sure that they should say therefore they should prevent those children from being released to their parents and go either way. But I can imagine you saying like, this experimental therapy is not beneficial for him, even though the family might think like this gives his death some meaning in some sense. And maybe in the case of the Indy Gregory, that this Hail Mary pitch for this heart surgery might be beneficial because we're not sure what the best thing is. So I guess I'm thinking about the questions about transfer that I haven't seen a lot of people talk about, and I'm curious if your views have thoughts on them. So thanks. This is for any one of y'all.
I'll take a stab at it. I hadn't really thought about, I think, so your question is, how do these frameworks work in, how would they provide guidance about potential transfer? Yeah. Well, so aside from this, I would say, I think there's compelling arguments to make to honor a parent's request for transfer in almost any situation. I think there are real downsides that families may have to weigh for themselves that include loss of social support, potential financial risk, not ever getting their child home if dying at home feels important. But I don't think that, at least, I don't think any of our frameworks would preclude the potential for transfer. I don't.
Yeah, I don't think. Yeah, I mean, certainly. Yeah, I mean, I think I would agree with that. Like, I mean, certainly from the kind of the meaningfulness standard, I mean, again, it would come down to a question, I think, similar to the previous question about just, I think, come down to the question of what does respecting the worth of this child look like? And I think there is a significant, at least for us, and this might be where we sort of overlap with peers as well, just in terms of the reasonable pluralism. I mean, I think there's a lot of room there to sort of discuss with the parents about what that looks like, what it should look like, and if that involves, transferring, I mean, that's something that could be on the table, yeah.
In a lot of these contentious cases, I think that one of the interesting questions about transfer, though, is what is the obligation of the provider to accept?
Yeah, sure.
And what weight does that acceptance or denial carry? And we could spend another hour talking about that, probably.
Thank you.
All right. Well, thank you so much for staying a few extra minutes here. And yeah, thank you, everyone, for your patience, your questions, participation, and thank you to the speakers, myself included.
For anybody who's going to the dinner, there are going to be signs to follow the U505 exhibit. That's where it is. So it's by the submarine exhibit. The signs are big and orange. So if you see a red sign, or an orange sign that says U505, follow that.
And if you had a coat, the coats are being moved over there. So that you don't have to worry about your coats being transferred over there.